through it pretty quickly, and I'll try to explain everything as best I can. So again, my name is David Janice, and I'll be doing lymphatics. So lymphatics is going to be primarily about the immunity that we're going to be demonstrating with our lymphocytes that are going to be in our various lymphatic organs, which brings us into what type of lymphatic organs that we have. Lymphocytes, like I said, are going to be the main cell, and that's going to be our B and T cells, as well as their derivatives and the ones that they're activated by and what they do activate. Lymphatics is going to monitor the internal and the external surfaces. So what that means is, just like we talk about in anatomy, with our lymph nodes, our regional lymph nodes, for our mucosal surfaces, they communicate with the lymphatic system, they communicate with the lymph nodes, they go into the bloodstream, and then it goes to the area of infection, which we'll see this process over and over again as we continue. And the main thing, it reacts to antigens. So anything that's foreign or external, it's going to react to that. So what is an antigen? Well, it induces an immune response. That is an antigen. And lymphocytes become immunocompetent, meaning that they're not going to kill the host. So our B and T cells aren't going to attack ourselves. And if we do have that, it's called an autoimmune disease. So this goes into what is self, or what's the body, versus what's non-self. So what's an antigen? And we educate and become mature in various places depending on the cell. So maturity is a very important concept to understand, especially when it comes to thymus is the T cell. They start with T, thymus equals T cell. Bone marrow is going to be the place where B cells are going to actually mature. Fun fact, the T cell comes from the bone marrow, all right, and then it goes to the thymus. So maturation site for the T cell is going to be in the thymus, but its creation is going to be in the bone marrow. So what is the immune response? It's separated into two different kinds, nonspecific and specific. If you think about the nonspecific as a broadsword, think of it as I don't have to mature, I don't have to do anything special except what I'm born with and what I can do just naturally without any time wasted. So this is going to be our physical and our skin, as well as our mucosal membranes, any type of barrier outside to the inside environment. Chemicals, so we have a good example, which is the skin. Dr. Maui wanted you to know that the 5.5 pH is on the neonatal skin. It's a little bit higher for adults. In addition to that, we also have stomach acid. So we can add stomach acid in here. And stomach acid, as we know, is going to be about 1. So that's going to kill essentially everything. Secretory substances like lysozyme from our sebaceous glands in our skin. Phagocytic cells also fall into this category of nonspecific immune response. And this includes macrophage, which this is the universal symbol for macrophage. It's going to be an M with a psi sign. Polymorphonucleoside, which are neutrophils, and our NK cells, which are a branch of the phagocytic cells in the nonspecific immune response. So our specific immune response is going to be a fallback if nonspecific fails. So if we have an inflammatory reaction that happens, say for example an antigen gets stuck inside your body and your normal macrophages can't get rid of it, we're going to have the big guns come out. So this is going to be the precise or precision elimination of antigens. This is going to be our B and our T cell. Remember, B is from bone marrow, T is for thymus, and that's where they go into maturity, and they're activated to destroy the invaders. So our humoral immunity, humoral bone, humerus, right? Just think about humerus. Humoral is going to be antibodies, and this is going to be our B cells. We're going to do opsonization, neutralization, and you'll learn about those things later on. Just know that the humoral, the B cells, antibodies. That's the connection that you need to make. Bone, B cell, antibodies. Our cellular is going to be T cells. This is our cellular mediated response, all right? And this is going to be regulated by our T cells, which, as we'll see later on, actually get separated into two other classes, CD8 and CD4 T cells. These are actually going to kill cancer cells, virus-infected cells, and they're going to actually activate the B cells. Okay, let's talk about our lymphocytes here. So remember, our B and T cell are going to be our specific, and our NK is going to be our non-specific. Don't forget that. Now we have what's labeled here in green are going to be antigen presenting cells. Our other supporting cells are listed in the white. Essentially all these are supporting cells. But our macrophages, epithelial reticular cells, dendritic cells, and Langerhans cells are all going to present and be antigen presenting cells. So not to get into too much detail, just remember that our B cell that's not listed quite on here yet will also antigen present as well. So of these, the dendritic cell, the Langerhans cell, and the macrophage will also present to CD8 positive T cells. The lymphocyte is characterized in just its size. So we have T, B, and NK. Remember, T and B are specific, NK is non-specific immune response. Our lymphocytes, small is going to be 6 micrometers, medium is 12, and large is 18 micrometers. And when they are in circulation, that means they are immunocompetent. That means that they have gone through the test, they will not self-react, and so therefore they will not harm the host. So what are CD markers? Well, technically they're called cluster of differentiation. The cluster of differentiation is essentially how cells recognize each other and allow processes to occur. And so it's a cell surface molecule. So if we have a cell right here, the CD4 molecule or the CD8 molecule or the CD46 molecule or the CD whatever number you want to say molecule is going to be on there. And that's how cells are able to recognize one another and do talking. So we use numbers to designate. And like I said before, we have CD4 positive, CD8 positive, and we have plenty of others which we'll go into in length in immuno next semester. So in order to see different cells, we use a process called immunohistochemistry, and what that is that antibodies are going to bind to these CD molecules on the cell surface, and they're actually going to light them up, and so that way we can sort them out, we can see them in fluorescence, so that way we can identify different cells. Okay, so T lymphocytes represent 60 to 80% of the lymphocyte population in the bloodstream. They differentiate in the thymus. Differentiation means maturation. They are responsible for a process called cell-mediated immunity, or short for CMI. Cell-mediated immunity is responsible for cell-to-cell interaction. That's how they're going to interact, and that's how they're going to facilitate their effect on the body. So they also have toll-like receptors, and they have CD markers. CD markers, like we said, are going to be the cluster of differentiation, and those are the actual cell surface receptors that enable cells to respond and recognize one another. CD4 is cell-mediated immunity. CD8, cell-mediated immunity. Treg, or T-cell regulators, are going to suppress immunity. So you'll see this in immuno whenever there's a problem, or if you have, for example, a CD4 T-cell that is self-reactive, that did slip by the maturation process, the Treg cells are going to be responsible for inhibiting those autoreactive or bad T-cells. Then we have our gamma delta T-cell, and this is going to be our first line of defense. So this is on the same level as the innate immunity, which we saw with non-specific immune responses. Our gamma delta T cells are going to be in our Peyer's patches, in our mucosal membranes. They're going to be the ones that respond first. They're not going to go back and do all this special song and dance like we see with the T and B cell. They're just going to react, and they're going to do an effect change right then. Okay, so T helper, also abbreviated as Th1 and Th2, which are subgroups. They have a T cell receptor, and they're also CD4 positive. They secrete cytokines. Cytokines are paracrine or autocrine signaling molecules that are secreted by the T cell to influence change via cellular receptors of other nearby cells or even itself. And by doing that, we can influence gene expression, protein production, and other changes inside the cell so that those cells can actually influence change in the environment, creating a macro signaling cascade in cases of an infection or immune reaction. So T cells also interact with all other lymphocytes. Very important. They have cell-mediated immune response and antibody-mediated immune response. And the antibody-mediated immune response, remember, it's not, the T cells don't make antibodies, but they activate B cells. All right? And remember that our T cells our T helper cells, CD4 specifically, is only going to recognize MHC class 2. I put in here MHC class 1 is for our CD8 T cell, which is our cytotoxic T cell. Our MHC class 2 is our CD4 T cell. So, CD8, cytotoxic T cell. They have a T cell receptor, and they're CD8 positive. They kill tumors. They kill virus-infected cells. And unfortunately, they are also responsible for transplant rejection. They secrete perforins and fragmentin. which another name, which I've never heard of fragmentin before this class, but granzyme is the appropriate name, and perforins and granzymes are the ones that are actually going to be secreted by the CD8 T cell, and that's actually going to cause the cell that it's interacting with to die by apoptosis. It's a controlled cell death. So remember, CD8 positive T cells are going to only react with MHC class 1, and its activation is to a non-self antigen that is bound with the MHC class 1, which we'll see examples of this later on. Just remember that MHC class 1 CD8 T cell non-self antigen. Okay, so B cells represent about 20 to 30% of the lymphocyte population. They were first found in the bursa fabricus, so it was an organ in a bird that they found these cells developing, to which they later identified in humans as the bone marrow or the GALT. So remember, gastro-associated lymphatic tissue, we also have BALT, but more specifically, it's the MALT as the overall concept, so mucosal-associated lymphatic tissue. Our CD markers, which you don't need to know for this test, but you will for the immunotest, 19, 20, 21, so just, if you can, put that in the file cabinet. B-cell receptors are going to be membrane-bound immunoglobulins, so that is the antigen binding site. So what that means is that you have a B-cell, and they have an immunoglobulin binding site, and what that is that they wait. They wait for the antigen to come in to that immunoglobulin binding site in order to be activated. And then what happens is that's internalized, and then MHC class 2, so remember, B cells are antigen presenting cells, they will present to the CD4 T cell to be activated itself, to activate the CD4 T cell so that it can activate other B cells. So as we can see here, activation of a B cell causes plasma cell, includes multiple antibody production, and memory B cells. Alright, so this picture is actually going to demonstrate how we have this autocrine and paracrine signaling in respect to the example we just gave in the last slide about B cells and CD4 positive T cells, or T helper cells. So upon activation with this antigen, here's the antigen, that's what AG stands for, and the B cell receptor, we have internalization of this antigen antibody complex into the B cell. It's processed through a various process inside the B cell, and then it's presented on MHC class 2, and here is that same antigen that was presented on the left here. So this antigen will then interact with this CD4 positive T cell with a myriad of different cluster of differentiation, or CD40 in this case, and then we have our CD4 as well as other cluster of differentiation. You don't need to know that. Just know that our B cell will interact with our CD4 T cell through MHC class 2. Here, CD4 will actually do autocrine signaling with IL-2, and then we have these other interleukins or cytokines. These other interleukins are going to operate and activate various other cells. You don't need to know which cells for the test. This is for your general information. We have basophils, eosinophils, we have macrophages being activated, as well as other processes that are being activated. From this point, we actually have those interleukins interacting with the B cell that originally, here, the B cell that originally activated the CD4 T cell. It is then super activated by the CD4 T cell and its interleukin secretions. And from here, we have our two forms of the B cell that's been activated. We have our plasma cell and our memory B cell, which we'll go over the specifics and the journey of that in just a moment. IFN gamma, interferon gamma, sometimes it's INF, doesn't matter, it's the same thing. So you'll notice that we have IFN down here and INF up here, so whatever. So IFN gamma is actually going to be the one that activates the NK cell, and what it does is that it waits until it encounters this antibody antigen complex. So when the antibody plus the antigen are combined, which we see right here, then we have this activation at the NK receptor, and then from there it secretes perforins and granzymes, which is just like CD8, and these perforins create holes inside this cell, and our granzymes are going to go in here and they're going to fragment the nucleus, and essentially you have apoptosis. Okay, so antigen-presenting cells. Remember, antigen-presenting cells for the most part are part of the monophagocytic system. or for short, the MPS. So we have macrophages, Kupffer cells, which are in the liver, Langerhans, which are in the skin, dendritic cells, which are going to be in the lymph nodes. Others include B lymphocytes, our 2, 3, 5 epithelial reticular cells, which are really responsible for our thymic education. So what that means is when T cells go there, they're going to experience and encounter these epithelial reticular cells, which will cause them to mature. And then we also have our other classification for these two, which are going to be our non-monocytic origins. Okay, so let's talk this out. So we have a virus going into a cell. A cell is saying, I know you're not supposed to be here. It'll secrete interferon, which is essentially the cell's safeguard to say, hey, I have a virus in here, protect yourself. So it signals other cells to protect themselves. In addition to that, it also signals immune cells to come near it, to kill it. So we have the presentation and processing of the cell. So this will be a non-self antigen. The non-self antigen will be presented on MHC class 1, which will be recognized by CD8, which will secrete perforin and granzyme into the cell. The cell will apoptose. The blebs will be taken into the macrophage. Macrophages will process those blebs, and it'll be presented on MHC class 2, so that the CD4 T cells are going to activate B cells as well as other T cells, and we have this whole process going on. So let's talk this out. So we have a virus-infected intestinal cell displaying viral proteins or antigen on MHC class 1, just like we saw before. So we have this MHC class 1. Well, that's when the cell's being processed. But what happens if the viral antigens actually escape the cell? So the viral antigens will escape it, and we have our macrophage right here. Our macrophage will take it in and process it. We have MHC class 2 presentation to CD4, so there's 1, and we have MHC class 1 presentation to CD8. There's number 2. Remember, CD8 are cytotoxic, so that means that they're going to kill cells that present this on their surface. The CD4 T cell will be activated, and by activating it, we'll have an increase of interleukin 2 or IL-2, not only to itself, which is autocrine, but also we have it for our paracrine for our CD8. Once activated, CD8s will go into the regional lymph node. From here, we have multiplication and differentiation of the CD8 T cells. So we have a clonal expansion of our CD8 T cells. From here, the CD8 T cells travel to the site of infection from the regional lymph node. So we have to go through the lymph, all right? Then we go into the bloodstream, all right? And from here, we go to the site of infection. How do they know where to go? Well, you'll learn about that in immuno, but these epithelial cells will actually secrete other receptors onto their cell membranes, causing these CD8 T cells to be stuck and roll in through diapedesis. Once they encounter these cells that have this MHC class 1, they'll secrete the perforins and granzymes and cause the cellular apoptosis, which we see here again. So we've seen 2 examples of how this happens now. To know this, non-capsulated. It is usually found in the lamina propria. All right, so gut is gall, respiratory is balt, and for the most part, it's found in gastrointestinal tract. So our black dots are going to be lymphocytes. So we have black dot, black dot, black dot, black dot, and we have the diffuse lymphatic tissue. All right, so diffuse lymphatic tissue, black dots. That's why we're stained here. These are what these stains are right around here. We have these stained. Those are lymphatic tissue. So it guards against pathogens, number 1. Great. Lymphocyte, macrophage, and plasma cells are all there, all right, secreting antibodies. More specifically, we're going to have our IgA and our IgM. Just FYI. These are going to intercept antigens. So our antibodies are going to intercept antigens. Our lymphocytes are going to intercept antigens. Now, will T cells actually be able to intercept with an antigen? No, they won't. They have to have macrophages, which is seen right here, to activate the T cells. Can CD8 T cells be activated by antigens? No, they must have macrophages or B cells or some other type of antigen-presenting cell to be activated. Will NK cells be able to be activated by antigens? Well, not unless they're bound with an antibody. So we have NK cell needs antigen antibody. Will T cell, so CD4, T4, and T8? No, needs antigen-presenting cell. B cell? Yeah, they can get antigen. All right, macrophage? Yeah, they can get antigen. All right, so this initiates the immune response once we have interception of the antigen. So our innate immune system, all right, so this would be our non-specific, when it falls or when it's not as efficient as it should be, then we go to our cell-mediated immune response or humoral immune response. And translating this is our T cell, and this is our B cell. The progeny will then return to the site via the lymphatics into the bloodstream back to the site. So this is where we are going to have our effector B and T cell, which have been activated. And honestly, which one is activated depends on the type of cell that is first encounters the antigen or has been activated with the antigen presenting cell. So we see right here, all these black dots, again, are going to be diffuse lymphatic tissue, and those are all lymphocytes. Okay, what is this? Well, it's going to be diffuse lymphatic tissue. Is it a Peyer's patch? Well, no, because we don't see a germinal center, but we do see a whole lot of lymphocytes. Okay, so this is again going to be in our mucosal associated lymphatic tissue. What are these? Well, from the digestive system, you'll know what type of cell they are. Use this as a review. Do we see any type of staining, or specifically like we've seen in the previous slides? Yes, we see our lymphatic tissue, our diffuse lymphatic tissue, our lymphocytes, and that's what these dark spots located in the middle of our villi are going to be. Okay, so now we're going to start talking about our lymphatic nodules and our Peyer's patches. So our lymphatic nodules are going to be an increase of reticular cells with reticular fibers. And remember, all that is we're creating a mesh, a big net to catch the trash or the antigen. So they are non-encapsulated. Very, 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 very important. It's going to be on your test. They are dark staining. All right. And you notice we have a lighter region and a darker region. We'll go over why that happens in a moment. So they have no afferent lymphatics, only efferent lymphatics. They develop into a germinal center, which germinal center is B and T. Depending on what layer you're looking at, the corona or the medulla, you will be able to tell which cells are there. And remember, like I already mentioned, they're surrounded by a corona, which is this area right here. Okay? Sites in which we have what? We have proliferation of B and T. Okay? So we mentioned before that we have regional lymph node for CD8 going there, and we also have local lymph nodes, and then we have our germinal centers as well. So we have multiple areas where our adaptive immune response can be activated. Okay, so let me use a metaphor here, the difference between a primary and secondary nodule. Our primary nodule is going to be when our antigen plus our lymphocyte are essentially going to a property that has already been bought by them. So imagine this marriage between the antigen and the lymphocyte. It's going to go to this property and start building a house. Okay? Start building a house. What that means is that we've already been activated. We already know what antigen is present. And so we're going to make essentially this big house just for that antigen and that lymphocyte that's been activated. So after they built the house, that's when it becomes a secondary nodule. This is a full-blown germinal center. It has a central region, and the B lymphocyte recognizes the antigen, returns to the primary nodule, like I said, to begin proliferation. And that's the beginning of our primary to secondary nodule transition. And large lymphocytes give lighter stains, which we'll see right here. And that's going to be our huge B cells, our huge lymphocytes that are actually growing and dividing in order to combat the antigen. And follicular dendritic cells. Remember, these are all going to be antigen presenting cells. 1, 2, 3. And the only one that's not is a plasma cell, because that is going to be our B cell that's been terminally differentiated into a plasma cell. So our germinal centers are responsible for their response to antigens. And we have mitotic figures are friggin'. What is a mitotic figure? Well, if you look, a mitotic figure is a cell in the middle of division. Or we have a cell that is starting to form our metaphase plate, whatever. It's cells that are actively dividing that you can truly see on a slide. So we have our germinal centers, for the most part, being very, very high in number and amount in the ileum, the tonsils, and the variform appendix. You need to know these three locations. The ileum, the tonsils, and the variform appendix are the areas of high concentration of germinal centers. Okay, so what is this? Well, this is going to be a germinal center zoomed in with high magnification. This is a physiological slide. You'll notice that I'll start to refer to them as physiological and pathological. If Dr. Maui hasn't responded to that already, pathological is when you see tissue that's abnormal, cancerous, or whatever. So this is a normal occurrence. You'll see very high amount of our lymphocytes that are on the periphery of this center. And in the center, we have our B cells, our really large cells. And this circle is expanded on the right here, and this is a mitotic figure. Remember metaphase plate, you can see the chromosomes starting to divide, and the nucleus has been already dissolved. So you have these cells, these really large cells that are actually dividing just in front of your eyes. Alright, so what's the corona? Well, it's the outer ring of small lymphocytes around the germinal center. So I've highlighted it in yellow. I didn't highlight all of it because I wanted you to see what it looks like without color on it. But you're going to see this ring, and that's indicative of the corona of a germinal center. What is this? Well, this is going to be our Peyer's patches, and this is going to be in our ileum. So we see here, here's our corona and our inside of our germinal center, and we have multiple here. So you need to be able to identify not only what part of the intestine this is, but also what are you looking at. Okay, so what is going on here? Well, we have enterocytes flanking both sides of this lumen here, and we have lymphocytes that are actively involved in this space. So what that's telling us is that we're going to have a frontline defense against any antigens that happen to diffuse across these areas. So that being said, we have our M cells right here, M cells. All right, our M cells are actually going to be the ones that will antigen process. Antigen process. M cells do not kill antigens, they process them. They're found in lymphatic nodules, in the Peyer's patches, and our M cells. Remember, Dr. Maui had to pay for the histological presentation of the M cells, so it's very important that you remember what their function is. Antigen presenting cells. They process antigens. So let's talk about B cell migration. Well, from the Peyer's patch, we have activation with an antigen. We go to a germinal center. From here, the B cells that are activated, that are dividing, then they'll go to the efferent lymph. So we have some that remain at the germinal center and continue to divide. But we need to get more. So we go to the efferent lymph and we go to a lymph node. From here, the B cells will migrate into that lymph node and then differentiate into plasma cells. Then they'll go to the blood. Those B cells will first have to go through the lymph, in the lymph node, to the blood. So this right here is just showing you the step that we skipped in 6. So 6 is lymph to blood, which if we got an infection in our stomach, we're going to go to our chili cisternae, and then from there we're going to go to the venous angle and back into the systemic circulation. Then, like I mentioned before, it's going to have specific cellular receptors to indicate where it needs to go. Then it's going to go there, and it's going to go through the blood to the affected area. These cells, these B cells, will then be effectively changed into plasma cells. So, just a quick note here, while we're still in the lymph node, some B cells will become plasma cells and secrete antibodies. Other B cells will go to step 6. So we have one B cell to plasma cell in the lymph node. We have the other one goes to blood. Then it goes to the area, and then it becomes a plasma cell. And then starting off at the beginning, we have our B cell to our Peyer's patch, and that is our plasma cell. So we have plasma cells being created at 3 different levels here. One in the lymph node, one in the at the actual site of location after it's already went through the lymph node, and the original one that was going into the primary and secondary germinal center. So all of this is for antibody production. B cells, antibody. The apical domain, here we have our villi, and then they go in, We have lymphocytes waiting for them, we have our macrophage ready to process them and do antigen presenting. Okay, so let's talk about our tonsils for a minute. Our pharyngeal or adenoid tonsils are consisting of pseudostratified ciliated columnar epithelium. The crypts are made of surface epithelium, okay? And if they're diseased, they become stratified squamous and, well, they can't do what they're supposed to do anymore. So they essentially become useless. I've highlighted here the crypt, okay? This is a tonsil, all right? So we have tonsils on both ends. Remember, pseudostratified ciliated columnar epithelium for the surface of our crypts. Okay, so let's talk about our palatine tonsils. There's going to be two of them, and they're going to be at the entrance of the throat. They're covered with stratified squamous epithelium. Okay, you remember what stratified squamous is? Are you going to find it on your skin? Yes, but they're not keratinized. Okay, keratinized is going to be on the skin. Stratified squamous is not going to be on the skin. It's non-keratinized in the mucosal membrane. So many deep crypts, and they may contain bacteria, cells, and lymphocytes, which is exactly what we need to have to combat our other antigens. Why would we have bacteria in our tonsils? Well, we do have normal flora bacteria that assist us in killing other pathogenic bacteria that may be introduced in our body. And then we have our patches right here for our mucosal associated lymphatic tissue, and this is where we're going to have our bacteria, our lymphocytes, and our macrophages ready to encounter antigens. So again, we have our stratified squamous epithelium, non-keratinized. We have our connective tissue, and then we have our lymphatic tissue right here. So our or lymph node rather. Okay. So our stratified squamous epithelium, tonsils. Stratified squamous epithelium, tonsils. Okay, so now we're going to talk about our lingual tonsils, which it completes the tonsillar ring, which is located in the posterior oropharynx, which, as you recall from anatomy, consisted of this ring that had all the different types of lymph nodes. So our lingual tonsil is located at the base of the tongue, versus our other tonsils were located at the back of the throat and the pillars of the throat. So our lingual tonsil is posterior to the circumvallate papill, which is on the tongue, and it's stratified squamous epithelium. You'll notice the trend here, stratified squamous epithelium. Alright, what is a lymph node? Well, it's shaped like a bean. It's encapsulated. This is the first time we've talked about an encapsulated organ in regards to the lymphatic tissue. Now we have, where do they go? Well, they go along the lymph vessels. So, for example, with our Peyer's patches, we had efferent only, so EFF, from the mucosal associated lymphatic tissue to the lymph nodes. So they receive the antigens and they receive the lymphocytes. So we have several major areas, so the axilla, the groin, and the mesenteries. They act as filters. That is their role. They filter out antigen. And they also have afferent and efferent vessels. Okay, so this is a histological presentation of a lymph node. Remember, it's bean-shaped, so we can see this general bean shape. All right, and we have the hilum, which is where we're going to have our entrance of our lymphatics and our exit. Also, we're going to have our medulla, which is the center, the cortex, all right, and our deep cortex, which these are all very important to understand what they do, and we'll cover that in just a moment. So again, another lymph node, and we have our concentration area. This is going to be a transverse section of a lymph node, so we can see our medulla, and we see our cortex, our deep cortex. So this line right here, this is going to be our deep cortex, our medulla, and our cortex. And then we have our lymph nodes right here, which is going to be our germinal centers. So our dense connective tissue consists of our capsule, okay? We want that because we don't want anything that's going in there to be thrown back out into the environment and cause havoc. Then we have separation into these like gross framework via the tubercula. So our tubercula are going to prevent any type of movement in between the compartments that they've essentially kind of created with the trabecula. So we have a reticular meshwork that consists of our reticular cells and our reticular fibers. Remember, they create a net. They intercept and present antigen, okay, and they're also creating support for the nodes. So they don't want the nodes to just collapse. They want them to have consistency, and that's granted by the reticular meshwork. All right, so reticular mesh. We have 4 different types. They are synthesize and secrete reticular fibers, and those fibers consist of type 3 collagen, which we can see. These are our reticular cells where the black arrows are pointing to, the thick arrows, and then the thin arrows are going to be the actual reticular processes that are being created. This network that's been created by these reticular cells and fibers, trying to search for antigen and clearing it out, as well as performing its antigen-presenting cell duties. So what is reticular mesh? Well, remember, we have 4 different types of reticular cells. They secrete the reticular fibers that are consistent of collagen type 3. We have dendritic cells, which are antigen-presenting cells. They present with MHC class 1 and MHC class 2, and they're found in the T-cell rich areas, which would make sense because we want to activate CD4 and CD8 with our dendritic cells. We also have our macrophages, which are going to be phagocytic cells. They also perform antigen-presenting cells, but their major role is going to be, number 1, phagocytosis. They also have MHC class 1 and MHC class 2 presentation, but like I said, that is their lesser role. Their main role is phagocytic functions to digest and internalize material so that it will not harm anything else. So our follicular dendritic cells, and we have these in the germinal cell and the lymph node, have hair-like processes that are woven in between the B cells. So there's no MHC class 2, so they don't actually perform any antigen-presenting cells to our CD4. Okay? So our follicular dendritic cells are going to kind of create this B cell nursery. And what that is that it's going to hold on to these B cells so that if a CD4 T cell comes in, the B cells are all localized in one spot, so the CD4 T cell doesn't have to waste time trying to search for things. In addition to that, the follicular dendritic cell will provide stimulation so that if a B cell does happen to be activated, then it can provide the associated signals to keep it going. So that's what this is going on. That might be a little too much information, but I just wanted to give you an idea. Follicular dendritic cell loves B cells, and it creates a B cell nursery for the activated B cells to be even more activated and become plasma cells. Okay? Let's parse this out. We have 3 different areas. We have the outer cortex, we have the inner cortex, and we have the medulla. The outer cortex consists of lymph tissue that also has the lymph nodes, which we see right here, which are going to be our lymph nodules, and our lymph sinus with lymph channels. And you'll see right here, we have this opening. This is the main difference to differentiate between a thymus and a lymph node. The thymus does not have this area right here. It is contiguous. Now, going over to the presentation on the left here, we have a histological presentation of the outer cortex where we have the lymphatic sinus and we have an afferent lymph vessel, which, as you can see right here, it does create a valve. So it does not go back into the afferent lymph. On the bottom right here, we have a lymph vessel, which you can see clearly taken from this slide, and you can see our lymph nodule right here. We have our corona on the outside and our medulla on the inside. Be sure that you're able to differentiate between the outer cortex, the inner cortex, and the medulla, which brings me into the inner cortex. This is also referred to as the deep cortex. It is also referred to as the thymus-dependent cortex. Thymus-dependent. So already we can deduce that our B cells are going to be in our outer cortex. Our T cells are going to be in our inner cortex. And in this inner cortex, we have high endothelial vessels, which are specialized end capillary venules that are going to be responsible for the exit of T cells from the bloodstream into the lymph nodes. We also have dendritic cells, which are professional antiprogenitic cells, and we have other lymphocytes present. So what's in the medulla? Well, it's the innermost part. So this square here kind of intercepted a little bit of the inner cortex and the outer cortex. I'll just correct it right there. So we have the outer cortex, the inner cortex, and we have the medulla. Remember, outer cortex is B, inner cortex is T, and our medulla is going to contain our cords of lymph tissue, specifically B cells, macrophages, dendritic cells, plasma cells. So this is where we're going to have that, like I was mentioning before, our B cells that have taken up residence in this lymph node, and they're going to be secreting our plasma cell product, which is our antibody. They're going to be supported by the medullary sinus that are going to be traversed by reticular cells and fibers. Remember, reticular cells are essentially creating reticular fibers that are going to provide structure. All right, and remember, our reticular cells create that mesh to catch things as well. Cells, and we have their fibers, and we have macrophages that are going around creating this web so that antigens get caught. And when they get caught, they can be either phagocytized by the macrophages, and then we have antigen presenting to alert the immune system that there's something in the lymph node. So, filtration. That is the main role of a lymph node. Here, this general flow from the afferent to the efferent lymph, we go to the subcapillary sinus via the afferent lymph. And remember, they are valved. They do not allow efferent to afferent flow. It's only afferent to efferent flow. From the subcapillary sinus, we go to the trabecular sinus. The trabecular, remember, are those wedges that create those different regions in the lymph node. From the trabecular sinus, we drain into the medullary sinus. And the medulla is where we're going to have this conglomeration of different lymphocytes that will be able to provide another means of filtration. So the subcapillary sinus is below the capsule and continuous with the capsule. What that means is that we have a space. So we have capsule, which remember is dense connective tissue, and then we have our outer cortex. And remember, we're going to have the ability for antigens to go from the subcapillary sinus into the cortex, okay? So our afrolymphatic is the one where our lymph is going to flow into, and remember, they are valved. They are discontinuous at the lymphatic parenchyma. What does that mean? Well, that means that we don't want antigens to come out via the capsule, so we have this ability for our antigens to go into the cortex. Our trabecular sinus is continuous with the trabecular tissue. Remember, I'll just draw this, okay? All right, so this is our capsule, remember, dense connective tissue. This is our cortex, and we'll draw another cortex right here, all right? And we have our trabecula. So we have antigens coming in here. So antigens can't go through the trabecula. This is a non-filterable substance, all right? But they can go into the cortex, all right? And that's very important because, like we said, it creates these compartments, and those compartments prevent the antigen just going wherever it wants to go. It's directed fluid flow. So the medullary is all discontinuous. So once it gets down to the medulla, or the medullary area right here, it can just go in, and that's the final aspect of the filtration. Our outer cortex, our deep cortex, our inner cortex, and our medulla. So you'll see that our cells can go in here whenever they want, all right? And what I've circled here, the subcapillary sinus right here, the trabecular sinus right here, and our medullary sinus right here. And then our high endothelial venules are going to be in the deep cortex so that our T cells can go out into them. So our lymph sinus is not an open space, okay? So what does that mean? Well, it's not just we can go wherever we want to go whenever we want to go, all right? We have macrophages and reticular fiber processes that essentially present to the different areas of the filtration system that's in place. And what that means is that the lymph node acts like a mechanical filter. All right, so this process has been elucidated over and over again, so I hope it's not annoying you, but we have our afferent going into our subcapsular sinus, into our trabecular sinus, into our medullary sinus, and out through the efferent lymph. Throughout this process, antigens will go into the outer cortex, they will go into the deep cortex, and they will go into the medullary sinus. So it gives them multiple opportunities for the antigen to be caught in this web that is provided by the macrophages and the reticular fiber processes that present these antigens to the various levels. So either we have our B cells, our T cells, or our grab bag, which consists of our macrophages, lymphocytes, and our plasma cells. So remember, plasma cells, they're just secreting antibodies, so they're kind of out of the equation for presentation, but our macrophages and lymphocytes for sure. So in the case we have an autoimmune issue, for example, we have cancer that's metastasizing the lymph node, this can be overwhelmed, and that's how we start to get this spread from lymph node to lymph node, and they have to take them out. Capsular sinus, we have our reticular cells that have the reticular fibers, and our macrophages with their processes essentially acting like a mechanical filter. And then we have our outer cortex, which antigens can freely go into. On the picture on the right, we have our separation, so our subcapsular sinus, our outer cortex, our inner cortex, and our medulla. Okay? And remember, our blood capillaries are going to go via our high endothelial venules, and that's going to be in the deep cortex. Okay, which brings us to high endothelial venules. So 10% of our lymphocytes are going to go by afferent lymph. Only 10 travel by the lymph. 90% on the other hand go via the postcapillary venule, or its other name, high endothelial venule. So it's located in the deep cortex. It's lined by cuboidal or columnar endothelium. They have receptors for antigen that's primed by the lymphocyte. So the lymphocyte is there waiting for its specific antigen. They signal for the lymphocyte to leave the blood if there is an infection. And they also reabsorb lymph, some of it, back into the blood to prevent fluid overload, and in cases of dehydration. So this is an example of a high endothelial venule. Just to draw the line here, we see it's one cell layer thick. This is our endothelial cell. And then we have these other cells, which are going to be the long arrows, and those are going to be lymphocytes that are actually progressing via diapedesis into the lymph node. Going out here, so this is going to be our basement membrane, and then we have our lymphocytes that are actually trying to go out into our other areas of the node, so our outer cortex. B and T lymphocytes enter the lymph node via the high endothelial venules via diapedesis. Diapedesis, very important that you know those words. So it migrates between the columnar or cuboidal endothelial cell, and the T lymphocyte will go to the inner cortex. The inner cortex, remember, is the deep cortical zone, or also known as the thymus-dependent cortex. The B lymphocytes migrate to the outer cortex. All right, so B outer, T inner, T deep cortical, T thymus-dependent, T inner cortex. Okay, so multiple names for the same thing. Lymphocyte leaves the lymph node via the lymph sinus. Okay, an efferent lymphatic vessel. All right, so remember we said that 10% go via our lymph. What's the other one? 90% go via our high endothelial venule. So, we've already established the lymph node is a filter. Antigens are trapped by the reticular fibers and the macrophage processes, as well as our follicular dendritic cells that are actually being the antigen presenting cells. They're going to be processed by them, I mean the antigen. So antigen is processed by the macrophage, by the dendritic cell, and by the B cell, because remember the B cell can be antigen presenting with MHC class 2. This leads to activation and differentiation of the B cell. Okay? And that B cell, once activated, is going to secrete antibody via plasma cell, or it's going to become a MEM-B, our memory B, or it's going to be an activated B that goes to the site of infection, and then it differentiates into the plasma cell, and then it secretes antibodies. Okay, so what happens to the B cell? Well, once they become activated, they go to the germinal center, so they'll go to a primary germinal center, they'll make it into a secondary germinal center, they'll undergo clonal expansion, then they become immunoblasts. So blast, like we've seen in the past, is going to be our progenitor cell. So we either have our B cell becoming a plasma cell in the lymph node, and from here, our antibody will then be secreted into the blood and lymph, which is good. So that's one option. The other option is the immunoblasts go to the site of infection, they become plasma cell and secrete antibodies. And the third option is we become MemB, and this is going to be for our secondary response, so a much quicker rapid response. Alright, so macrophages, immunocytes, and then we have mitosis. So what do you think this is? Well, if you said this is going to be a germinal center, you'd be right, because we have our macrophages that are present. We also have mitosis occurring with our mitotic figures. Remember, mitotic figures is a buzzword for thinking, okay, well, I have active cell differentiation. This is a site that most likely is going to be an area where our immune system, because those are really rapidly growing cells. Okay, so let's switch gears to the thymus. The thymus is the area where T cells are going to be matured. Remember, T cells are actually going to be created in the bone marrow, and they travel via the blood into the thymus in order to undergo thymic maturation. The thymus structure consists of a capsule that is made of connective tissue. We also have trabeculae, which we've seen in the lymph node, that separate the organ into different compartments that consist of the parenchyma. The parenchyma is the functional tissue within the organ, and in this case, we're going to have the cortex and the medulla. As we saw with the lymphatic nodules inside the Peyer's patches, or the mucosal associated lymphatic tissue, we only have efferent lymph, no afferent. So the thymus is not actually a active antigen presenting organ. It is the case that we want the T cells to be matured so that they can then undergo activation when the time comes. The thymus' purpose is to prevent T cells that are autoreactive or causing damage to the cell of the host from being released and causing damage inside of the host. So we also have blood vessels and nerves in the thymus. The trabeculae create domains or thymic lobes. These thymic lobes are essentially cortical caps over the medullary tissue. And what that means is that we have the medulla, or the medullary tissue, and then we have our cortex over it. Continuing along with the thymic structure, the cortex is very basophilic, so it stains very dark blue, with an increased number of densely packed lymphocytes. The medulla is the inner portion, and there's going to be a decreased amount of lymphocytes, so it's going to be lighter stained. Here we have an example of the thymus, as well as a transect cut of the thymus. So on the left, we have the thymus, and we can see our cortex and our medulla. On the right, we have the medulla and the cortex. Remember, we also have blood vessels, and we have efferent lymph only that isn't shown in these segments. So, how do we tell the difference between the thymus and a lymph node? Like I alluded to before, the lymph node is going to have the subcapsular sinus. The thymus does not. If you look right here, the capsule is contiguous with the cortex. The cortex is very basophilic, so it's very blue, and it has a great deal of T cells, which we'll see in a moment why that's significant. We have an increased number of macrophages with phagocytosis due to T cells that were autoreactive or they failed to react at all, and so therefore they are disposed of. We can see the PAS cells, which are going to be these red cells right here. Remember, our capsule is going to be contiguous with our cortex. We do not have a subcapsular sinus in the thymus. Okay, so this right here is a cross-section of the thymus, and we can tell it's the thymus because these are all T lymphocytes. In addition to that, we have our blood vessels right here, this would most likely be an artery or an arteriole, and that's going to be our venule or vein. And we know that this is not a lymph node because there's no subcapsular sinus, it's just contiguous. Okay, so this slide, although it appears complicated, once you understand the roles of the cells, it's much easier. So 1, 3, and 4 are all structural. They prevent movement of the T cells. 2 is responsible for positive selection, and positive selection means that if the T cell autoreacts or reacts against self cells, then it will be eliminated and processed by the macrophages. Type 5 epithelial reticular cell presents negative selection, and what that is that if the T cell does not become CD8 or CD4 positive, it is eliminated. Type 6 Hassel's corpuscle secrete specific hormones that are responsible for thymic development. You'll notice that we have the postcapillary venule, and this is where our immature T cells, or our naive T cells, are going to come from the bone marrow, go through the medulla, go through 4 and 3 epithelial reticular cell, and attach to the type 1 epithelial reticular cell, and then we have the process to begin for maturation. So, the thymus. Well, first of all, the specific type of cell that we're talking about is the CFU-L, which is the stem cell for our T cell. We have our thymosin and our thymopoietin being secreted by the thymus to assist in the development of the thymus, as well as secreting to the bone marrow to increase the levels of thymocyte production by the bone marrow so that it can replace T cells in the case of T cell loss. So T lymphocytes are thymocytes when they're mature. The epithelial reticular cells are attached by desmosomes or occluding junctions, and they perform the reticular meshwork that's responsible for barrier contribution, which we saw in 1, 3, and 4, as well as the maturation process of the T cell, which we saw with 2 and 5. In addition, they also form cytoplasmic reticulum, which is very important for our mesh to keep the T cells in a structured, ordered process so that they can undergo the maturation process and prevent autoreactive T cells. Remember, this is going to be a test question. There are no reticular fibers in the thymus. No reticular fibers in the thymus. Here are different types of cells are. So we have one on the outside. Okay, and we have the capsule. We don't see the capsule, but just imagine this red line's the capsule. Then we have our our epithelial reticular cell 2 in here, in the outer or the cortex. Then we have 3 and 4 demonstrated by the red and the green highlighter right there. And then intermixed in here, we're going to have epithelial reticular cell 5, and then we have our high endothelial venules and our Hassel corpuscle, or our type 6 epithelial reticular cell. So let's go over these a little bit more specifically. You will need to know if they create a barrier, you will need to know if they create an occluding junction, you will need to know if they're structural, and you will need to know their location inside of the thymus. So type 1, it's structural. It separates the cortical parenchyma from the exterior, i.e. the capsule. It is bound by an occluding junction, and it does provide a barrier. Type 3, structural. It's between the cortex and the medulla. It does have occluding junctions that connect the cells together, and it does provide a barrier. Type 4 is structural. It's between the cortex and the medulla. That's what those arrows mean. It's the same thing. It is bound by occluding junction, and it does provide a barrier. Remember, type 3 is on the cortex side, and medulla is on and type 4 is on the medulla side, and they are all structural. Okay, so this is another example of our thymus. You'll see we have the capsule, the cortex, and the medulla. We do not have a subcapsular sinus, which we would see here, and this is what differentiates the thymus from the lymph node. In the cortex, we have type 1 epithelial reticular cells, which is indicated by the yellow line. Then we have type 2 that's interlaced, and that's going to be responsible for a selection process. Then we have our type 3 and our type 4, which are bound together with occluding junctions individually, and they provide a barrier. One's on the cortex side, which would be the type 3. One's on the medulla side, which would be the type 4. Then we have the thymic corpuscles, which another name for that is Haskell corpuscle or type 6 epithelial reticular cell. And type 5 is intermixed inside the medulla, and that's going to be responsible for another selection process, so that at the end we will be able to have mature T lymphocytes, specifically CD4 and CD8, that will travel out of the thymus via the hind epithelial into the blood circulation. Okay, so let's talk about the actual functional cells that are outside of the structural cells, which remember were type 1, 3, and 4. So type 2 is supporting and developing T cell, has large euchromatic nucleus, and there are desmosomes that are present to keep it attached to others. And remember, we have crosstalk between the different types of 2 that are together inside of the cortex. Type 5 creates a meshwork between groups of lymphocytes, and they're also joined by desmosomes in order to facilitate this kind of involved maturation process of the lymphocyte. Type 6 is called the Haskell corpuscle, which we'll go over that in just a moment. So right here, we have examples of type 2. So type 2, remember, cortex, epithelial reticular cell, cortex, selection, medulla. And those are going to be type 6 or epithelial reticular cell. They're concentrically arranged, so they look kind of like this helix or tornado. In the center may appear keratinized. They may also have calcium. Very important, they originate from the oropharyngeal epithelial derivative. All right, so they have a different origin than what you think it would, since the thymus lies above the heart in the fetus. In the neonate, the oropharyngeal epithelial derivative is a little far away from where it needed to be. So, needless to say, they are the functionally active components of the medulla, and they generate thymosin and thymopoietin. So here are just some examples of our Haskell corpuscle, and the arrows are pointing to our type 5 cells that are going to be responsible for our selection. So what happens when we get older? Well, come puberty, our thymus starts to involute. Okay, so thymic involution happens when we get older, and our essential parenchyma of the thymus is replaced by fat. So we're still producing new lymphocytes, just not at the level that we were when we were young. So we're still able to re-stimulate that adipocyte tissue, and then we re-differentiate it back into thymic parenchyma in the demand for T cells if we ever do take a big hit. So what's the blood-thymic barrier? Well, the thymus is a privileged area, meaning that we don't have the thymus exposed to antigens that we encounter every day. So blood vessels keep lymphocytes isolated from the blood-borne antigens. And what that means is, remember, we only allow our T cells that need to be matured into the thymus. In addition to that, we only allow those T lymphocytes that have undergone the process of positive and negative selection out of the thymus. We also have several layers of checks and balances in terms of structural cells that are bound by desmosomes, i.e. type 1, type 3, and type 4. In addition to that, we also have a very thick connective tissue capsule that prevents anything from coming in that way as well. So it's essentially impermeable. Okay, so this cartoon image is going to show a blood vessel as it travels through the thymus. So how do we prevent things from going into the thymus that aren't supposed to be there? Well, number one, the basal lamina. The basal lamina is going to prevent antigens, step 1. We also have macrophages in the perivascular connective tissue, and those macrophages are going to engulf anything that will attempt to try and get in. In addition to that, we have extensive tight junctions provided by the type 1 epithelial reticular cells that are located contiguously with the perivascular connective tissue that is going to prevent any type of cellular movement from that vessel that is not supposed to be there. So remember, we have no afferent lymphatics, so we're not actually providing any type of antigen stimulus to these T cells either. So just remember, the thymus has no afferent lymphatics, only efferent lymphatics. It has an extensive privileged area that is essentially impermeable to any type of antigens that can cross-react with these developing T cells. Okay, so what's the spleen? Well, it's also a blood filtration organ. And specifically, it's going to do blood-borne antigens. It's the largest lymphatic organ, and it has a lot of lymphocytes, red blood cells, macrophages, and dendritic cells. So it's a specialized vascular space with channels. And what that is that we have different types of methods that red blood cells, white blood cells can interact with one another, as well as the white blood cells interacting with the blood as it flows through. So again, we have a meshwork of reticular cells and fibers. Where did we see that before? Was it in the thymus? Absolutely not. The thymus has no reticular fibers. Was it in the lymph nodes? Yes. We have reticular fibers and reticular cells there. The spleen is going to monitor the blood for antigen, and it's similar to the lymph node for lymph. So the spleen doesn't receive lymph, but this is analogous. This is a relationship that we can draw conclusions from. Not so much. If we're going off of our outer cortex and medulla, we could kind of swing that. But here you're going to see differences in stain. So you're going to see white pulp and red pulp. You're going to see these areas where we're going to have our lymphocytes that are surrounding our vessels. So just to start off, again, we have capsule, which we've seen several times now, our trabeculae with great compartments. And now we introduce the concept of pulp. So we have our white blood cells and our white pulp, and our red blood cells are going to have blood that's surrounded by white pulp, which is very important, and we'll explore that in just a moment. Okay, so again, we need to be able to differentiate between the different types of tissue. We have our capsule and trabeculae. That doesn't help us differentiate. Subcapsular sinus, no, so we can eliminate our lymph node. Now we're left with two options. We're left with a thymus, and we're left with the spleen. And then we look at what's in here. In the spleen, we see our red pulp, which is red, and then we have these kind of big, round germinal centers, or our splenic nodules. That is where we're going to have the site of B cell proliferation. We did not have that in the thymus. We had a cortex where we had a lot of lymphocytes. Then we had a medulla where we had lymphocytes as well, that we had Haskell's corpuscles. These are not Haskell's corpuscles. Do not be confused. So the spleen capsule, capsule of dense connective tissue. We saw that in the other two examples. Trabeculae extended to the pulp. Again, similarities. They have myofibroblasts. Well, this is new. We didn't have those in the other ones. They're contractile and also produce extracellular connective tissue fibers. In addition to that, we also have the spleen performing another function of storage of the RBC. So what that means is that these myofibroblasts, which are a different form of muscle cells that we've seen before in our muscle chapter, but the contraction causes forced release of stored blood from the spleen. Now, that's not to say the human spleen is a great reservoir. It only retains a little bit, so it can make minor bumps in blood concentration. Okay, so on the left here, again, differentiating between the thymus and the lymph node and the spleen. Again, we have our capsule, our trabeculae. Do we see a subcapsular sinus? No, so it can't be a lymph node. Now we're left with two options, the spleen and the thymus. Is it the thymus? Well, I don't know, but this looks like a germinal center, so that's probably not the thymus. It's going to be the spleen. So here we have our, on the right we have a trichrome stain. We have our capsule, our trabeculae, and our white pulp, and then we have red pulp in here with lymphocytes surrounding it. So the spleen capsule, all right, the hilum has a splenic arterial and venous supply coming in, nerves and lymph nodes, or excuse me, lymph vessels. Then this is going to have white pulp near the trabeculae, and that's why we've seen in the trichrome stain in the previous example, they're pretty much out there in the spleen. The white pulp is going to be basophilic. The reason for this is because we're going to have lymphocytes with the dense heterochromatin in the nuclei. So we're going to have a number of lymphocytes, and so we're going to have our deep blue stain. So our white pulp here, we're going to have it surrounding these vessels. And so our branches of a splenic artery, they exit the capsule and the trabeculae. The flow of blood to the white pulp, all right, and we have our splenic artery going to our central artery. So lymphocytes collect around the central artery, and this is where we start to see our pals. So our pals, we have pals in the spleen, and our pals is the periarterial lymphatic sheath, and it's cylindrical and conforms to the central artery, which is very important for immune function, which we'll see in just a moment. The presentation on the left are going to be the T lymphocytes. This right here is going to be our central artery. What happens when it gets activated? Well, we have a displacement of the central artery to an eccentric position. Before, our central artery was in the middle and our T lymphocytes surrounded it. But as you can see in these two examples on the left, especially the one on the bottom left, originally most likely the central artery was going to be centrally placed, but it's been pushed outward by the germinal center due to a reaction of the B lymphocytes, the T lymphocytes, and subsequent activation of B lymphocytes into this germinal center, also known as the splenic nodule. So there are B cells in this node now. The germinal center is a reaction center due to antigen stimulation and our activation of B cells with their subsequent mitotic divisions. So these are also referred to as Malpighian corpuscles. Very important that when you cover renal, that you do not confuse the Malpighian corpuscles of the spleen with the Malpighian corpuscles of the renal system, also known as the renal corpuscle. Okay, so our red pulp is red blood cells. This is due to the increased number of red blood cells that are there. These also have splenic sinuses that the red blood cells will be able to go into that are separated by splenic cords, which are also referred to as the cords of Billroth. Cords of Billroth are going to be compartmentalizing the splenic sinuses so that red blood cells can flow in and out of different regions, and they'll actually have to flow through the reticular cells and fibers that are present, creating a meshwork. Remember, we saw this same concept being applied in lymph nodes, but instead of red blood cells as they're flowing through, we were talking about lymph as it flows through the lymph nodes. So remember, the reticular cells and fibers create a meshwork that possesses red blood cells, macrophages, lymphocytes, plasma cells, dendritic cells, and granulocytes. So granulocytes, just to name a few, eosinophils and basophils. So our macrophages actually destroy red blood cells and begin the heme breakdown and iron reclamation. So this is going to be our iron 2 plus reclamation. So remember, destruction of red blood cells happens every 120 days. So this is where we refer to as senescent red blood cells. And on the left here, we can see that our S stands for the sinuses and our C stands for our cords of Billroth. Again, these histological presentations are going to be representative of the spleen, and on the upper left, we have our splenic sinus, and we have our cords of Billroth. On the lower left, we have our red blood cells and our splenic sinus. In addition to that, we have our cords of Billroth coming in around, okay? And this right here is a silver stain, and this silver stain is going to be staining for our cords of Billroth and how they form these intricate sinuses and enable the red blood cells to flow within. Endothelium that resemble barrel-like endothelium, and it's a discontinuous basal lamina. We've seen this concept in the liver whenever we have our space of Dis. It's a discontinuous endothelium that encapsulates or covers the microvilli that originate from the hepatocytes. So this is a little different, but it's the same general concept. These barrel staves, or these openings in this discontinuous basal lamina, which we see right here, this is basal lamina, which is the light white, and the dark is the space that's created. We see that macrophages and neutrophils are waiting underneath or inferior at the basal side of the endothelium, that it's waiting for the antigens to pass by it so that it can grab it. And you can see these arrows pointing to macrophage processes that are actually reaching out through the barrel staves in order to attach to antigens that may be precariously traveling through. So our venous sinus is sinusoidal vessels. They have a basket-like endothelium. They're extremely long cells with many gaps, so they're discontinuous. So as red blood cells and blood passes, the macrophage processes have the chance to sample the blood. So there are no smooth muscle and no pericytes inside of this endothelium that is unique to the spleen. So on the left here, we have another example of the discontinuous basal lamina in the spleen, like the the barrel staves. And then we have the picture in the middle, or slide B, we have another silver stain of what it looks like with these discontinuous basal lamina. And on the right here, on the cartoon B, we see that our endothelium is actually just essentially wrapping around in a perpendicular fashion to this endothelial cells. So our basal lamina is the one that's going in one direction, our endothelial cells are going another, creating this cross-like pattern as the macrophages reach in through the barrel staves of the discontinuous basal lamina in between the long endothelial cells in order to sample the environment in order to eliminate pathogens that may be encountered in the spleen. Okay, so this brings us to our final concept, the splenic circulation. So the splenic artery will go into the white pulp via the trabeculae, and from here we'll go to the central arteries. Then, from the central arteries, we branch into a smaller form, which is the penicillar arterioles, which, as we saw in the previous slide, where we had our perpendicular basal lamina to our long endothelial cells. From this point, the perpendicular cells will enable the macrophages to reach in and sample the blood that's traveling through in order to remove the different type of antigens. Now, there is a conceptual disagreement onto how the blood actually travels through the spleen. So one is that we have open circulation, which, as we can see right here, we actually have the penicillar arteries essentially draining out into the red pulp so that we have a lot of perfusion, and in addition to that, we have actual contact with the macrophages in the blood product in order to increase the amount of efficiency for antigen removal. The other theory that's explained is closed circulation, and closed circulation would really be important whenever we have to get blood through the spleen very quickly without having it just kind of go into the red pulp and then be reabsorbed. So this right here would be indicative of, okay, well, we need blood quickly, we need it to go through quickly. The spleen, we don't really need to be processing antigen right now, we need blood to go to the muscles and heart. So in this example or theoretical model, the splenic artery will go to the white pulp, to the central artery, to the penicillar arteries, which are going to be sheath capillaries, and then we go into the splenic sinus and out again through the hilum. So experimental evidence has supported the open mode because of the increase of efficient exposure of red blood cells to macrophages and red pulp, but there also is the closed mode, which is when we need to essentially shunt blood and move blood very quickly. Presentation by the antigen presenting cells, so the macrophages and dendritic cells. We also have activation and proliferation of B and T cells, as we saw with PALs in the red pulp. We have antibody production by the B cells that have been activated. We have the clearance of macromolecules or antigens from the blood, very, very important filtration function. We also have the erythropoiesis during the fetal blood development or the fetal development. So if you haven't learned it already, remember we have the yolk sac going to the spleen, then we have the liver, and then we also have our bone marrow being the final area where we have blood cell development. We also have the clearance and destruction of senile red blood cells or senescent red blood cells, and that is after the 120 days, they've already done their duty, the macrophages are going to destroy them, and they're going to reclaim their heme, which we'll cover in the next slide. So we also have destruction of abnormal red blood cells. This can be really bad in the cases of, say, for example, sickle cell, where almost all the red blood cells are damaged with a person who has sickle cell disease. And we can also remove damaged platelets that can cause havoc inside of our cells, our vessels. So the spleen function continued. Like I mentioned before, we retrieve the ferrous particles from the hemoglobin as the red blood cell is broken down. Remember, there are millions and millions of hemoglobin molecules in red blood cells, so it's very important that we reclaim that iron, especially for women that undergo menstruation. If we didn't have this, then anemia would be a much more prevalent issue, especially with the monthly menstrual cycle. So with our iron, it's stored as ferritin and hemidesrin, and we also can break down the heme protein to bilirubin that's then replaced to the liver so that we can increase the efficiency and we don't have to expend so much energy to make our heme every time that we have red blood cell breakdown. So the spleen is not essential, although all these functions are very important. If the spleen has to be removed due to trauma or due to disease, the liver will take over the functions after it's removed. Question, and then just continue.